let's just start talking about the mechanism of action for the SMA treatments. I will focus on the SMN modifying therapies, which are listed in that first panel, but first cover a little bit of the SMN-Independent therapies. And these are therapies, the ones that I'm going to talk about, that primarily focus on muscle and that are being studied as an adjuvant to SMN modifying therapies and are not standalone agents. These are the two. One is a myostatin inhibitor. This is Wendy. She's myostatin deficient and has, as you can see, muscular overgrowth. SRK-015 is a intravenous antibody administered, which is anti-promyostatin, with the idea that in SMA patients who are on nusinersen, with the hope that it will improve strength. Those studies are not yet completed, and we await those results. The other muscle-acting agent is the troponin calcium activating agent called reldesemtiv. This is a little further along. It has a phase 2 trial that showed, among a variety of patients with SMA, that there were changes in the distance walked on patients who had been on doses of reldesemtiv that were dose-related and also had some effects on breathing. Let's talk about the SMN modifying treatment. As Perry very eloquently told you earlier, what's deficient in SMA is SMN protein. This SMN protein depletion results in loss of motor neurons, so we replenish it by gene transfer, which is using the AAV9 to introduce a human SMN gene that will produce the functional SMN protein we are missing, as you can see in the middle panel. And on the right-hand panel are the mRNA-based therapies, which are all based on the SMN2 gene, which, as you heard, produces a non-functional protein that's missing that exon 7. This delta 7 is non-functional, but if you can include exon 7, you can make it into a functional SMN protein. And that alternative splicing, which is called, makes more SMN protein out of SMN2. And that's where risdiplam and nusinersen work.